Okay. Commissioner Cruz and Ron, I know you are standing in today for Commissioner Cruz. Thank you for being here. Commissioner Mazziotti, I heard you already.
I'm here.
Commissioner Holton. Commissioner Archer, and I see Jill says she's running a few minutes late and will join us a little bit later. So I will put her down as a possibly yes later. Commissioner Hupy.
Present.
Commissioner Minty. Commissioner Godwin. Vice Chair Gowie-Ran.
Here and present.
Commissioner Clarkson, and I'm sorry, Nate, I forwarded this to Tony, and I think I forgot to forward it to you. Commissioner Clarkson already emailed and said she had a conflict this afternoon. And Chair Vesna has a conflict. Commissioner Nordyke. Commissioner Obiero. Commissioner Biglin. Right. And then is there anyone here representing Senator Solomon's office? They may be joining in just a few minutes. And is there anybody representing Representative Reynolds' office?
Hello. Yes, I am here on her behalf. This is Christopher McMorrin.
Hi, Christopher. Thank you so much.
Thank you. I'm also in the car, so I probably won't be talking a lot, but I'll be listening.
No worries. All right. Vice Chair Gowie-Ran, Tori, and I will continue monitoring who is in attendance for commissioners. We are not voting on anything today, so we don't have a quorum issue, but just for maintaining attendance, we'll keep monitoring who is joining us late.
Okay, great. Thank you, Acting Director of the ADPC. So next on the agenda, we have Elizabeth Waddell. Dr. Waddell, good to see you. Thanks for being here. Dr. Waddell was or is a former commissioner to the Alcohol and Drug Policy Commission. So she's going to do a presentation on the opioid overdose after release from prison, a retrospective study using Oregon administrative data. So with that, Dr. Waddell, thanks for being here.
Thanks for having me. And I want to acknowledge upfront that this was a massive undertaking that required collaboration with DOC, Integrated Client Services Data Warehouse, OHA, multiple statisticians. So it really took a village to get this done. And it was the first data linkage of its kind in Oregon, where we were able to link some pretty detailed administrative data from DOC with OHA data and Medicaid data and hospital discharge data. And of course, all of this research was approved through institutional review boards at OHSU and federal review boards protecting adults in custody. And everything was de-identified. So no risk of sharing personal information for the former adults in custody who are included in these analyses. So I will share my screen and yes, sharing screen. Awesome. And I just figured out how to put your faces back up on the other screen. So things are going really well. So I'm going to share at a pretty high level findings from our paper that was just published in the Journal of Substance Use and Addiction Treatment. There's a link to the full article on the agenda, and then you can also copy and paste the link here. I sent the slides to interim director Gray moments ago. So she has them to distribute to the group. So the lead author on this paper is Dr. Dan Hartung. Whole team worked on the analysis, and it was funded by my grant from Centers for Disease Control and Prevention. This was the same grant that funded the Reducing Overdose After Release from Incarceration ROAR pilot, which happened in Coffee Creek, where we were able to identify 64 women who were interested in starting extended release naltrexone before their release. And we worked with certified recovery mentors to help them get into treatment and followed them for 6 months. Results from that research are coming soon. Okay, so for this big administrative data analysis, what we did was link prison release administrative data, hospital discharge data, and death records from the state of Oregon. And these were for adults in custody who released from prison, not jails. This is prison only, between 2014 and 2017. And we followed everyone in the administrative data for a year to see who had a fatal or a non-fatal overdose event. So we use statistical models to estimate the risk of fatal and non-fatal overdoses among these adults who were released within the past year. We looked at different subpopulations to see if there were risk factors for overdose among certain folks. So we looked at time from release. We looked at individuals with a documented mental health treatment need, documented substance abuse treatment need, and these were from the DOC administrative records. We looked at gender, male versus female. We looked at having a drug charge. And we chose not to look at race ethnicity because the race classification data from that time, 2014 to 2017, were not reliable. And we were worried that we would misrepresent risk among, in particular, Hispanic race ethnicity, as well as Native populations. And Devarshi, I think you're going to talk a little bit about race classification in your slides.
I will, yeah.
Okay. So we calculated the fatal and non-fatal overdoses per 100,000 population, and that was so it could be comparable to national overdose rates. So overdoses were only counted for folks who showed up in emergency department or were admitted to hospitals. We did not have access to, for example, ambulance data, the EMT data for folks who were not transported to hospital, and for overdoses that happened at home and were revived with Narcan. We also had access to death certificates for individuals who had a fatality in Oregon. I won't go into the detail, anyone who's interested in the statistical models, but we use statistical models to identify really important predictors of overdose risk. For the clinicians in the room, we identified opioid-involved overdose using standard classification tools. So the opioid poisonings that we identified included opium, heroin, methadone, other opioids, and synthetic narcotics, which is predominantly fentanyl. Encounters originating in the emergency department were identified using billing codes. We used OHP claims for inpatient admissions as a primary indicator of a hospital admission. And we were also able to supplement those visits with data from hospital admissions from the Oregon's hospital discharge database. So that contains admissions data from all payers. So I'm showing these tables from the paper, but I'm gonna highlight a few things that are really important takeaways from the study. These are demographics of the 18,258 folks who were released during this period, 2014 to 2017. So this is a significant number of adults being released from prison back into community. Most of them are male, 86.6%. Much smaller population of our adults in custody in Oregon are female. Again, this is 2014 to 2017, but Devarshi, I don't think that this male-female split has changed much over the last couple of years. I want to talk a little bit about differences in risk factors for women in custody and prison versus men. So we know both from data in Oregon as well as national data that women in prison are more likely than their male counterparts to have mental health diagnoses, often more severe than the men, and co-occurring substance use disorders. Women are coming into custody generally with experiences of trauma, interpersonal violence, a lot of risk factors that need treatment both while in custody as well as without. We were really interested as part of the ROAR study for identifying and documenting increased risk for overdose, knowing that our women are at even higher risk for these kinds of events after release. So if we look at the documented substance use treatment need, again, these are known treatment needs that are coming from health records, self-report. So underestimated likely, 67% of the men who were released between 2014 and 67% of the releases between these years, 2014 and 2017, had a known substance use disorder treatment need, but 84% of the women and 64% of the men. And, you know, again, I want to leave it to Devarshi to kind of talk about these trends, but I think we know now that these rates are even higher of known substance use disorders. Most of them did not have any drug offenses documented. Nevertheless, we wanted to look to see if those who had a drug offense as part of the reason why they were in prison had a higher rate of overdose. We see 17% overall of the folks who were released had any drug offense. 16% of the men, 24% almost of the women had a drug offense. When we look at mental health treatment needs, 20% of the prison population overall had a documented mental health treatment need, but that's double among the women. So 46% of the women, 16.5% of men. So this is kind of a busy table. So again, I want to go over kind of the key takeaways. The overdose rate here, which is 1,000 overdose events per 100,000 people in a year, is about 1.5 times higher for women releasing than for men. There's a huge difference in overdose rate among the folks who had the documented substance use treatment need, right? So 490 compared to almost 1,400. So having this documented substance use treatment need is a really strong indicator of overdose at release. So Devarshi is going to talk more about this, but I want to be clear that between 2014 and 2017, the treatment that was available within Department of Corrections is much less than it is now. Drug offense, we don't see any big differences between risk of overdose. This is whether or not they had any drug offense. Mental health need, again, is a huge predictor of overdose. So we're comparing 950, a rate of 950 compared to a rate of 1,600. So almost double. So we see that so this population with a known substance use treatment need, and this population with a known mental health treatment need, there's quite a bit of overlap because we see co-occurring conditions are huge risk factors. When do these overdoses happen? They're happening within 2 weeks of the gate. So we see that kind of surviving that first 2 weeks is critical. And then I don't want to get into Devarshi's presentation, but the one important sort of treatment and implication for release planning is really helping folks get through those first 2 weeks safely. So these are the regression models. Here we're looking at rates and how they're different between certain populations. And now we're trying to see which factors are really significant, like holding everything constant. The gender effect kind of falls out when we are controlling at the same time for the mental health treatment need and the substance use treatment need. We did some additional analysis to see why that may be. And it's really because there's such a huge difference in the population of women compared to the population of men. Women have much higher rates of treatment, substance use treatment need and mental health treatment need. So that is how we're explaining this huge gender differences between males and females. Drug offenses, not important. Age, not important. So a summary of findings. What we've been able to show here is the rate of fatal and non-fatal overdoses is more than 10 times the rate in the general population nationally. The risk for fatal and non-fatal overdose is the worst for everyone in that first 14 days after release. The risk is higher among females, and the risk is higher, whether you're male or female, if you have a documented substance use treatment need or excuse me, there's an error here, and Jill, I'm going to resend the slides with the correction. This should say documented substance use treatment need or mental health treatment need. And then the rate of fatal overdose, again, 20 times greater than our general population. So some implications, and we'll get into this more, I think, when Devarshi talks about treatment. We know that justice-involved populations in prison, of course, and in jail and in community corrections have very high rates of substance use disorder. Adults released from prison in Oregon have really high rates of fatal and non-fatal overdose that are many times higher than the general population, both within our state and nationally. So what do? We need to continue to refine our tools and strategies, not only to treat specifically to the population, but help us screen better for those who are at high risk, especially incarcerated women. So there are likely implications for programming within Coffee Creek that might look a little bit different than what's done for the men in the other facilities. DOC is already scaling up programs to ensure that adults in custody have access to medications for opioid use disorder, including buprenorphine, both oral and injectable, during and after their release to community. And it's not just treatment within the jail, a lot of increased attention to the importance of release planning. And that is really most effective, we know, when recovery mentors are involved in that release planning and can help ease the transition into treatment. And you have that twice. So Jill, I'm going to send you corrected slides to go out to the group. And we can take questions now, or maybe even after Devarshi's talk, because he may answer a lot of your questions. So up to you.
I'll look at the chair, Vice Chair Gary Rand. How would you like to do questions?
Thank you, Dr. Waddell, for your presentation. Yeah, let's just run into Devarshi's presentation and then we'll take questions at the end if you're all okay with that.
Sounds like people are okay with that.
Okay, go ahead,
All
sir.
right. My screen visible to everybody? Great. Okay, so I'm gonna apologize ahead of time. I put this together at the last minute. There's no fancy transitions or animations, and it sounds like I got all the spelling right, which I'm very happy about. There's my buddy Mike. Look at that. Hey, Mike. So I'm going to be talking about what the Department of Corrections is doing for substance use disorders. I'll talk about generally what substance use looks like within Oregon DOC population, what we're doing regarding medications for opioid use disorder, and then talk about the Senate bill that we have going through right now, Senate Bill 529, and the governor's recommended budget and how that affects DOC. I wanted to talk. I've been trying to, since I took on this role last June, I talked a couple times with Dr. Richardson and other members of the commission to see if I could get on the agenda, because I think we really need to think about people that are in DOC custody. 98%, 99% of them are going to be released to the community. And I'm afraid that what our state has done really in the past has really forgotten about these people. So they go into ODOC custody and we kind of forget about them, and then they show up on our radars again when they get out. But really, a DOC is part of the community system, and everybody's going to be coming back to the community, and we want them to be ready to be successful when they get out. So that's really been my focus in this role. But it started before I started here. So in 2019, the legislature passed House Bill 2257. And the bill recognized substance use disorders as a chronic health condition or chronic illness for which commensurate treatment should be available and provided. It directed us, the Department of Corrections, to study what that would mean for us. So historically, how we've treated substance use, so just to give an idea of what the scale is, and Dr. Waddell mentioned this already, 63% of the DOC population has a substance use treatment need. That's based on an initial screening that's done when people are coming into our custody. It's self-administered, so it probably underestimates the amount of substance use disorders that are in our custody, but this is the best information that we have. So 2/3, that's more than 4 times greater than the community prevalence of substance use disorders. So it's, yeah, and 50% of those people are considered severe by that same screening tool. In developing our report to the legislature, so we reported back to the legislature, I think it was July or August of 2020, and everybody, reasonably so, was really focused on COVID at the time, and this report didn't get a lot of attention at the time. But when we were developing our report and reporting back to the legislature on what treating substance use as a chronic health condition would mean, we did focus groups of people that are in our custody, people that had been in our custody, people in the community corrections, community treatment providers, and really tried to focus on the voices of BIPOC and LGBTQIA plus communities as we were getting feedback on what we should do differently. The strongest recommendations that we got from the focus groups were that we needed to expand access to substance use disorder treatment. We had to give more opportunities for people in custody to get treatment, and I'll talk a second about what I mean by not just pre-release. Greater utilization of peer-based services and recruitment of more treatment staff with lived experience and from BIPOC communities. I know that's something that the community is also struggling with, getting our workforce, as this group has done a great job illuminating for everybody. There's a lot of work to be done there. So our recommendations were put into a report that we took back to the legislature in 2020. and was a foundation for a POP, a policy option package that the Department of Corrections submitted this year to expand substance use treatment for people in custody. The way to think about how the department has dealt with substance use in the past is that we've treated it as something that is there to reduce recidivism. We've treated it as a criminal justice measure, not as a health condition. What that means is that the only time we treat substance use disorder is right before somebody's about to be released. So it's in the 6 months prior to their release. People that are eligible for the alternative incarceration program, which only is 18% of our population, those people can get into these treatment programs and they're given a chance to get a significant reduction on their sentence. A little bit more than 20% of their sentence can be reduced by completing a treatment program right at the end of custody, and then they're released. When we think about other chronic health conditions, when somebody comes into the Department of Corrections that has diabetes, has a diagnosis of diabetes, we do an assessment and we decide what the appropriate treatment for that person is. So that person might just need diet and exercise, and they might be able to manage their diabetes and blood sugar with that. They might need oral medication. They may need continuous glucose monitoring. They may require injectable insulin. So there's a range of treatment options that are available, and we start treating it from the minute that somebody comes in. If diet and exercise doesn't work, we don't say, well, this person's not motivated, so you can come back when you are motivated, hopefully before you die. But as we all know, historically, that's often how we've treated substance use. So that if we're treating substance use as a chronic health condition, we have to start identifying it right at intake when people are coming into our custody, start treating it immediately, and have a range of treatment options available for people, including professional treatment, including medications, including peer-based services, and helping people live with their condition, which can mean, being focusing on some of those things that aren't really clearly related to substance use, like living skills, cooking, job skills, all that kind of stuff. Those are all things that help people with a chronic health condition. So we have not treated it that way, and so that's really what we reported back in our report on 2257, is that if we want to start treating it like a health condition, we need to think of it that way, a range of treatment options from the time that somebody comes into our custody. Just some more data, and this data might be a little bit different than what Dr. Waddell presented, because Dr. Waddell was looking at a population of people that are released. I'm looking at a population of people that are in our custody, so it's like who's in our custody at any given time. The populations are different because some people have longer prison sentences. Those people tend to be people with that are coming to DOC for person crimes, violent crimes, sex crimes. So the numbers are a little different, but we show basically the same thing, that about 2/3 of our population has a substance use treatment need. Native Americans are overrepresented in that group. So we see the same thing with women having an overrepresentation of substance use disorder. Again, this number is different than the one that Dr. Waddell talked about because of this, who was in custody versus who was releasing. And like I said, only 19%, I said 18, 19% of the Oregon DOC population is eligible for alternative incarceration program, the program that they have to, that if they complete treatment, they get a reduction in their sentence. The group of people that is eligible has a higher prevalence of substance use need, but really what's happened in DOC for the last few years is that these people, the people that were not eligible for AIP, the 81% of our population that wasn't eligible for AIP has not gotten any professional treatment services. They have access to 12-step meetings, except during the pandemic, of course, when we weren't having volunteers coming in. But generally, this group has not gotten any attention to their substance use disorders. So again, we're seeing if we can expand our substance use treatment to people that are not eligible for AIP, it's going to be Native Americans and women that are going to disproportionately be impacted by that increased access. So let me talk about medications for a minute. During the pandemic, the biggest drug that was smuggled into prisons was Suboxone by far. It was not even close. There was no other drug that was even close. When we looked at our UAs were far higher for Suboxone than they were for any other drug. And partly that's because it can be hidden in mail. Those strips can be hidden all kinds of places to get them into prisons. During that time, we didn't have visitation. We didn't have outside work crews going out at first. So a lot of the other avenues for drugs to get into prisons was cut off. But the biggest drug that we had coming in was Suboxone, which is not something that we really think of as a drug of abuse generally. I mean, I guess it can be, but it's not a very good one. So when we started looking at doing medications for opioid use disorder, one of the things that we were aware of is that there's a lot of Suboxone coming in. Generally, as a drug, as a medication, Suboxone is not dangerous. I'm not concerned at all about people in custody using Suboxone. What I am concerned about is that it's a current form of currency for exploitation. So when people are bringing drugs in, they can get people to do other things for them. And a lot of criminal behavior gets tied to that. So it's that idea of a black market that's really problematic in a prison environment, can create real safety security issues. Even though the medication itself is not dangerous, the behaviors that go on around it are pretty dangerous. So when we started talking about doing medications for OUD, we had some alarm about that and some wariness about it because we didn't want a lot of diversion going on and creating more incentives for people to kind of take advantage of each other. So that was something we were wary about, but being aware that so many people were overdosing, that it was such a huge public health crisis that was going on, we started doing medications in October, November of 2021. I think it was November, but it only included people, AICs are adults in custody. That's what that's our word for inmates in Oregon. It included AICs that were within 13 months of release with a documented opioid use disorder. We have our behavioral health staff assess people that say that they have an opioid use disorder and provide that diagnosis. We use two medications. We use Sublocade, which is a 30-day injectable formulation of buprenorphine, and Vivitrol, which is a 30-day injectable formulation of naltrexone. Dr. Waddell was talking about the research that we did around the Roar project that looked at using Vivitrol. This pilot really expanded it to institutions besides Coffee Creek, but also expanded the use of Sublocade. One of the reasons we picked Sublocade is because it's an injection. It's much harder to divert. You can't remove an injection. People might try, but it's not very effective. So the risk of diversion is why we use Sublocade. And it has an additional benefit in that it's a 30-day thing. So when we're releasing people, they have an injection that is giving them a bridge of 30 days past that 2-week period that Dr. Waddell talked about, where people are at highest risk for overdose. If they have either of these medications on board, the risk of overdose is much lower, and they're much better protected. Where if they're on an oral dose of Sublocade or Suboxone, they would have to be taking it every day, and it takes a few days for it to wear off, but doesn't give them that long-term protection that the injectable medications do. So during the pilot period, 510 AICs received Sublocade. 18 of them received Vivitrol. That was based on AIC choice. So I would love to say that people in Oregon prisons are not using drugs, and I would be completely wrong if I were to say that. People are using drugs. For people to take Vivitrol, they have to have a period of abstinence before they can take it, or it precipitates withdrawal. They go into immediate withdrawal. So a lot of people that were picking Sublocade over Vivitrol were choosing it for that reason, because they had been using, hopefully sporadically, but still they've been using, and they didn't want to go through that detox period to get Vivitrol. So back in November, we tracked 90 of the people that had gotten this medication. None of them have been revoked as of that time. We're going to continue to watch this. I hate using recidivism as a measure when we're treating a chronic health condition. Nobody looks at how well treating diabetes does at reducing recidivism. But we do that with substance use. So I don't think of substance use as a way to reduce recidivism, but we did think that this was important enough to watch that we have watched it. Also, I should note that at that same point in October, November, when we started doing Sublocade, we also started including naloxone in release kits. Every AIC who is released, all 4,000-ish people that are released every year are receiving naloxone. They're receiving one box with 2 doses in them. One of the things that we've been talking about recently is that with the amount of fentanyl that's going around, 2 doses of naloxone are often not enough to reverse a overdose. And so we're going to be considering increasing how much people are leaving with. The other thing I want to note here is that the 510 people in the pilot period, so it was a 1-year pilot period. The pilot has ended, and now it's our normal process now to do medication-assisted treatment for people that are within 13 months of release. But during that period, that 1-year period, we treated 510 people that were releasing to the community. We release about 4,000 people per year. So we got to somewhere around 11 or 12% of the people that were released in that year during the pilot program. Our real broad estimate of prevalence of opioid use disorder within that releasing population is somewhere between 15 to 20%. So we got to a significant portion of the people that were releasing with an opioid use disorder during that pilot period, and I'm hoping that that continues to expand. We also try to time the injections for Sublocade or Vivitrol shortly before release, so they get the maximum bridging period into the community where they're going to be protected and protected from overdose, and they're going to have time to find a provider that can continue their medication in the community. We're doing some work with Washington County and Care Oregon and Fora Health to look at those transitions of care and make sure that we're doing everything we can to remove barriers for people that are going back to the community and make sure that they can continue their medication when they get out. This shows how many of a subset of those people, how many of them received, how many injections that they received before they left. We had some people get full 12 months. We had a couple people get full 12 months of Sublocade before they left. We had a lot of people that were getting their first dose right before leaving, which is still great. Although this was during the pilot period, so we were still getting the word out in our institutions that this was a possibility that people could take advantage of. I hope to see this get that we have more people more stabilized before they leave in the future. So moving on from medications, I'll talk a little bit about treatment. Like I said, almost all of our treatment right now is through AIP, the Alternative Incarceration Program that only 19% of our population qualifies for. The AIP statute says that we have to provide 14 hours a day of highly structured and regimented routine every day. That the program must be 270 days in duration, 180 days of treatment, and 90 days of non-prison leave, during which they're in the community, but they're still technically under DOC custody and can be returned to prison with a revocation of their time cut to their sentence if they don't follow through with what they're supposed to do. So if you think about 6 months of treatment, 14 hours a day, 7 days a week, I mean, there's like nobody in the community that does that anywhere that I'm aware of. And this is the only place probably in statute that I can think of where a treatment program is prescribed for a chronic health condition. This is like saying that anybody that has diabetes is going to have to be on insulin, and there's no individualizing this. So we worked with Senator Dembro to craft Senate Bill 529. And if you look at this statement, it kind of gives you an idea of how we've changed how we think about substance use disorder. So the italicized portion is what was in statute before, that the AIP program, the point of it was diverting sentence offenders from a traditional correctional setting, that we needed a program that instills discipline, enhances self-esteem, and promotes alternatives to criminal behavior. And it has a major impact on overcrowding of prisons and criminal recidivism. So when AIP was initially drafted, and it was well intended, I'm not like questioning the motives of the people that did this, but it was really focused on, it was a correctional intervention. It was the point of it was to reduce recidivism and get people out of prison. You can see how we've changed how we think about it in the bold language, which is what this would be. This Senate bill would be adding to the statute, that substance use disorder should be considered chronic illnesses for which effective treatment is available. So the rest of the bill gives us more flexibility in how we implement our AIP programs. It eliminates a 14-hour day requirement and allows us to, there's been people that qualified that were found eligible for AIP at sentencing, but they couldn't get into programs because they have, if they have a mental health issue and they're on medications that make them sleepy, they can't do 14 hours a day and they wouldn't be able to make it in those programs. If they have a physical disability, they may not be able to go to get to all their groups. And so they weren't able to take advantage of those programs. Passage of 7 in Bill 529 will give us flexibility to be able to serve those people in our custody and be able to get them into AIP programs. It'll also, because it'll be less resource intensive per person, we'll be able to serve some people that are not eligible for AIP in these programs, and that's what we're hoping to do. So I said that all on the next slide. The other thing that we're looking at doing is creating a more normalized environment in later stages of treatment. So right now, the way it's structured, you have 14 hours a day, 7 days a week of structured activities up until the day you leave DOC custody. If with the passage of Senate Bill 529, what we'll be able to do is create more in later stages of treatment. We can have people going to work during the day, coming back, living more in a normalized environment where they're not doing treatment from the time they wake up to the time they go to bed. So we're hopeful for this. Senator Denbrough sponsored it. So far, it's passed the Senate and has a hearing in the House Judiciary on Monday, this coming Monday. If people are inclined to come testify and support, I would be thrilled to have some backup there. So I got that plug in. The other thing that we have going on right now is the governor's recommended budget includes an expansion of substance use services to 2 of our institutions. So we focused on the Oregon State Penitentiary and Snake River Correctional Institution. Between those 2 institutions, they're 2 largest institutions. They comprise 34% of the people in our custody with substance use disorders. And one thing I forgot to mention on this slide is that we're doing the same expansion at Coffee Creek, where, like we mentioned, we have the highest concentration of people with substance use disorders. We're just doing that with existing resources, and it's not included in the governor's recommended budget. So between the 3 institutions, OSP, Snake River, and Coffee Creek, will be covering about 44% of the people that are in our custody with a substance use disorder. But this proposal in particular, the expansion of 2 institutions, includes 33 staff. One of the concerns I've heard from community providers and is that we'll be recruiting staff from a very limited workforce that exists right now. One of the things I like to point out, though, is that the model that we have that we're using within prisons is that our CADCs are supervising peer mentors. So we're training people that are in our custody to be peer mentors. They're getting, through MACBO, they're getting the certification as CRMs, and some of them are moving on to CADCs while they're in our custody. So ultimately, we'll be providing more back to the workforce than we're taking out of it. We've already had a number of people that have been released from our custody that have gone on to work at community agencies and are doing amazing work in the community. Part of the peer mentor program, and this is a pilot that we started, this is the thing that I'm going to end with here. About a year ago, Nick Crapser, who was a behavioral health manager in the state penitentiary, who now works at Serenity Lane, he came to us and he said, I have something like 10 peer mentors that have been trained up here and they'd like some work to do. We'd like to set up a diversion program. So the way it's worked historically is that if somebody has a positive UA for a drug that's considered like contraband kind of thing, and they were given sanction for that of segregation. So they were put in disciplinary segregation. It's not what you think of with solitary confinement. People are not solitary in Oregon prisons, but it is a punishment. And so they'd receive a punishment and then they'd go about their business. Like I said, we didn't have a lot of treatment resources to offer people, so it was just a punishment, and somehow that doesn't make people get better, obviously. So they came to us with this proposal that we would create a diversion program so people would not be punished for a positive UA if they were willing to go through a pretty intensive program for 6 months with peer mentors guiding this. And so our peer mentors helped us develop the curriculum for this. They've helped us develop the program and policies for it. And we've run almost 200 people through this program so far. Not that they've completed, it's only been going for about 9 months, but we've had a couple of completions so far, but 200 people that are involved in the program, overwhelming demand for it. People are volunteering to be in the program. They don't have to have a positive UA. They don't have to get in trouble. So what we're finding is that when we offer people services in DOC institutions with absolutely no, they're not avoiding any punishment. They're not avoiding any prison sentence. When we just offer those services, people are taking us up on that. People want help when they're in our custody. So I'm really hopeful that the governor's recommended budget, that this will get funded through the legislature this year, and will really expand the substance use services that we have in our for people in our custody. My ultimate hope is that these two proposals together, Senate Bill 529 and the governor's recommended budget, will allow us to create a couple of our prisons where our AIP programs are right now, CRCI, Coffee Creek, and Powder River on the east side of the state. Those prisons will become largely recovery focused. So we'll have people that are getting into recovery at Snake River, at OSP, Columbia River, Powder River. And so hopefully we can start setting up kind of a self-governing institution at Powder River and CRCI where people will be supporting each other in their recovery and getting ready to be released and go back to the community. So that's my master plan in the end. So that's my presentation. I think Dr. Waddell and I can answer questions or however you'd like to do that.
Yeah, thank you very much, both of you, for your presentations. I'd like to open it up to the commissioners for questions at this time. Jill, I'm having a hard time seeing the hands raised and identifying who has questions. So could you help me out there?
Yep, I think the first one was Commissioner Obiero.
Thanks, Jill. Thank you, Chair. I'm going to see if I can get on camera here real quick for my question. Thank you so much, Dr. Waddell and Dr. Devarshi as well. I wanted to follow up with some of the information that you provided us as it relates to the overdose in particular post-release. And I have a personal stake in it because I work at the Multnomah County Jail, so it's very interesting information to hear. I'm curious, with the data that you all kind of studied, what do you anticipate the difference would be? I guess the first question is, will there be a repeat study? Secondly, and the reason I ask that more importantly is because we've seen since the study, based in 2016, I think you said, there's been so much changes in the way of what we're seeing with fentanyl and synthetic drugs that are causing a lot more damage than even years past. What do you anticipate, a study like yours would show in our current climate and what we are seeing out in the community with the fentanyl issue and with the synthetic substances as well?
So I'll take this, and I'd love Devarshi to weigh in on this too. So in the past year, we know that overdose in Oregon generally has increased about 40%. And that's compared to 16% right nationally. So fentanyl in our drug supply is clearly very deadly, and it's increasing overdose risk for anyone who's using opioids or other drugs, or fentanyl's creeping in. We are planning to repeat the study. Right now, our team is in the process of refreshing the database to include releases through 2020. And my team is strategizing with the research team at DOC to see if we can get some funding to, go forward and look at trends into the future. So the short answer is, whatever we see now, it's probably much worse. And the stakes are really a lot higher in that 2 weeks post-release. I also want to, I know you're at Multnomah County Jail, like these are prison data. It's a lot easier to do release planning and to get to know the needs of folks who are in prison. Most of them are there for over 12 months. We know that within our jails, most of the folks are in and out in a day, 2 days, less than a week. Hopefully, they get onto a withdrawal protocol. Hopefully, they can advocate for themselves to get into like existing MAT programs that are part of release planning, but it's really, really, really hard to catch them. So again, the overdose risk we see is 10 times higher for folks leaving prison. Some of that is due to release tolerance. A lot of that is due to the stresses of coming back to community. And just based on what I have seen and the limited work that I've done in jails in the Portland area, I would say the risk is much higher and harder to address.
And then there's just a quick follow-up question to that for Dr. Dvarsky. With DOC, I know you talked about buprenorphine and some kind of a treatment modalities that you're using. Are you all using Sublocade, and have you looked into that? I know that it can be pretty cost prohibitive, but just curious about that. Given post-release, people take a while to get into treatment, and these housing issues as well. Looking into Sublocade obviously would ensure that you have something on board that's more longer term. So just curious if that's something that you all have considered.
Yeah, that actually is what we're using. We're using Sublocade and Vivitrol. Both of them are extended release injectable formulations that give people about a month to be able to find providers and get stabilized in the community before they need to get another dose.
Okay, Catherine.
There we go. So the new expanded program that gets people into treatment sooner, on medications sooner, is that something that needs to be, is that part of AIP and therefore needs to be in the judgment, or is that something people can just get into?
So up until now, the only thing that's been available to people is, and they had to be found in the judgment to be eligible for AIP. What we want to do is expand services beyond that population because it's a fairly small portion of our total population. So medication-assisted treatment medications are available to anybody, whether or not they're eligible for AIP. And our goal is to make just general substance use treatment available for people, whether or not they're eligible for AIP.
Any other questions from commissioners? Okay, I'll open it up to the public
Chairman.
for a question. Oh, go ahead. Is that Dawn?
Yeah, Nate, thank you.
Go ahead.
I have a question. Yeah, the question I have, and I really think this is an excellent research effort. Do either of our presenters recommend any policies for the commission, understanding that there's legislation proposed, but beyond that, do you believe that the commission needs to investigate an appropriate policy approach to your research? Thank you.
Dr. Waddell, do you want to start or?
Actually, I'll go second, Dvarsky, because you are in the weeds with the policy work.
Okay. I mean, I think our governor's recommended budget expands substance use treatment to 2 of our institutions, OSP and Snake River. I mean, I'm hopeful that this is the beginning of that, not the end of it. So if the ADPC is interested in advocating for everybody in DOC custody that needs substance use treatment to get some level of that addressed, I think that would be one. I think it would have a huge impact on people in custody and the community. And yeah, other than that, I think I'm not sure of other policy things. I mean, I guess this is what we've been working on so far. I'm not sure what the next steps are beyond this, I guess.
I can jump in more generally, and I think that everyone in this room knows that funding is a challenge. We right now don't have a way to bill Medicaid, Medicare for healthcare expenses among adults in custody. There are many people working in Oregon to see if we can get some Medicaid reimbursements. First for release planning and connection to care. And I think some of that has gone through. Someone else will know the details. Jill, you're nodding your head. But anyway, to support the state's efforts to use our Medicaid waiver to support medications as well as release planning for those on the way out. Any way to provide additional resources to cover the costs of expensive medications is critical. In addition to supporting budget for peers within the facilities and for peers who are able to connect to treatment. We know that peer services are reimbursable by OHP under some pretty specific circumstances. It's really hard to reimburse peers and cover those costs for folks who are in that kind of pre-treatment area, like if they're not already engaged in services where the peers are employed. So those are really kind of big pots of funds that we don't have sustainable ways to keep those programs going.
Thanks very much. I would defer to Jill and the chair in terms of any kind of action by the commission, but I certainly support a follow-up to this research.
Yeah, this is Jill, Don. Just to piggyback on something that Dr. Waddell said. So I see Nicole Corbin from OHA is here. And Nicole, if I misstate anything, please jump in and tell me so. But part of the Medicaid waiver that OHA submitted to CMS, to the Centers for Medicare and Medicaid Services, included trying to provide some types of pre-release services using Medicaid funding so that people who were incarcerated would already be kind of hooked up to their medical providers and their medical needs before their release date. My understanding is that CMS didn't say yes or no on that particular portion of the waiver, but instead said they wanted to have more discussion about it. And my other understanding is there are other states asking for something similar. So it's really a group of states that are negotiating with CMS about how to make that happen. So at the moment, I think we're in kind of this limbo area where there are still these high-level discussions going on at the federal level about how to make that pre-release Medicaid option available. I will say from ADPC's perspective, we already submitted comments to OHA about several items in the waiver application. This was one of them that we said we were in full support of. So I just want to make it clear that ADPC has already put on the record and stated vociferously that we are in support of trying to make that transition from incarceration to being released a much easier process for people going through that transition. And I will stop there because I see Nicole has raised her hand and I probably said something incorrect.
Hi, everyone. You did, but it was hopeful incorrect. We did in the two things that OHA asked for from CMS in our waiver that they denied were Medicaid coverage for people who are incarcerated and paying for peer services outside of a traditional episode of care, right? We wanted exactly what Dr. Waddell was just mentioning. We wanted to, and what Devarshi brought up, we wanted to talk about, can we get peers to engage with people when maybe they aren't quite ready to come into treatment, and can we have them also support people after treatment? Medicaid denied both of those options, so we don't have those as part of our waiver right now. They did say, as Jill mentioned, that they were open to having a conversation about that in the future. Pardon me. So we have we're 2 years into a 5-year demonstration waiver. Obviously, we're hoping that we show successful outcomes in that waiver, and they indicated that they would be open to a conversation about that again when it was time to renew the waiver. There are several other states that are in conversations right now because nobody wants to wait that long, right? Because we're seeing overdose deaths. We're seeing an increase in fentanyl. We're seeing increased urgency. So there are conversations happening with Medicaid right now, but I want to be clear that there has not been any affirmative support from CMS yet.
Thank you.
Thanks, Nicole. Go ahead, Devarshi.
Yeah, and just one other clarification to add to that. Thanks, Nicole. Good to see you. One clarification to add to that is that it wouldn't have DOC billing Medicaid for services, but what it would allow is things like in the last 90 days of somebody's custody, treatment providers from the community could be billing Medicaid for reach-in services where they're connecting with the person before they leave to ensure a good transition to care rather than waiting until the day that they leave and then trying to find them in the community.
Go ahead, Dr. Waddell.
So just building on what Devarshi and Nicole are describing. So we had the CDC funded ROAR pilot, which again was 64 women who were interested in starting Vivitrol pre-release. And we were able to cover the costs of mentors with grant money to do the reach-in visits. And then once they were enrolled with our partner agencies, which were CODA and Bridgeway Recovery, then some of the costs of those services were reimbursable by Medicaid. So it worked great when we had mentors and a very clear workflow for holding an appointment. And then once they were registered, at their first appointment, make sure the OHP was all set up. But it really required a lot of pre-work before the release. And it's that work that was covered by the CDC grant dollars, which of course went away.
Thank you, Dr. Waddell. There is a question in the chat from Jill Archer, and it says, and pharmacy, question mark.
Oh, yeah, thanks. I was just asking about if the coverage extended while they were still incarcerated and service providers could bill for InReach. Could we also cover pharmacy costs?
Jill, I think pharmacy would be covered by DOC until somebody released, but I think if there were
Okay.
any prior auth requirements that we were running into, I don't think there are anymore, but if we were to run into any prior auth issues, we could get those resolved prior to
Before
somebody.
they leave. Okay,
Yeah.
cool. Thanks.
And that's exactly what we did in ROAR. So we had great support from Care Oregon to make sure that our participants who started in DOC wouldn't run into any Vivitrol pre-authorization requirements. And then we also worked with the CCO who was at that time serving folks in the Salem area. So the support of the CCOs is critical.
Any other questions from commissioners at this time? I'd like to open it up to the public. Any questions from the rest of the public? Jill, are you seeing any? I am not either. Okay, thank you both for your presentations, and they'll be available to the rest of the public, right, and distributed for the commissioners probably very soon. So thank you both. Looks like we are complete with our agenda items. Just officially, though, I'd like to generally open it up to public comment for the Alcohol and Drug Policy Commission. And if there's any public comment from anybody. Seeing and hearing none, I'll give it a few more seconds. Okay, we will close that agenda item, which is agenda item number 4, and move to wrap up and adjourning.
Vice Chair Gowron, I had one item to tell everybody very quickly, if it's okay to do that now.
Please.
So for commissioners, everybody, I just wanted to make sure, I believe we have introduced her before, but I just want to make sure everyone knows we have a new administrative assistant at ADPC. Her name is Karina Hopkins. And one of the items that Karina is helping us with is making sure that everything for our meetings is posted ahead of time, which we have not done very well because we were lacking that support in the past. So for every commissioners, public, I just want to make sure you know that we are going to do a much better job from here moving forward, making sure commission meetings and materials for those meetings are posted on our website beforehand. And if you have any questions or need any assistance, now you know we have a person here who can help you with that, and it is Karina. And Karina, are you on? Let's see.
I am.
Karina, would you like to take just a minute to introduce yourself to everyone?
Hi, I'm Karina Hopkins. It's nice to meet you all.
And now that you've heard that she is a very helpful person, please feel free to reach out to Karina with any assistance you need. Thanks, Vice Chair Gowron.
Okay, with that, any other comments from commissioners? Well, we're going to give you back some of your afternoon that was scheduled. So it is 2:08 and I officially close this meeting. Thank you, everyone.